Good morning. Loga ya is Hawaii. Jem will so some laha. What's up with me? Giskas. The move lot. Good morning. My name is Loga ya. My given name is Dwayne Jackson. I am of the Giskas. The Giskas clan of the Gitmax, of the Gitsan, of the Timtian, of the people of Tamlaham and Old Hazelton. I am one of the co-chairs here with the Aboriginal Steering Committee with the Human Early Learning Partnership. Before we move on, I would like to welcome Musqueam Knowledge Keeper Shane Point, and he's going to come up and open us up in a very good way and welcome us to this beautiful, beautiful territory. Shane, thank you.
Wow, that's a Musqueam word. Wow. Another Musqueam word. Awesome. Oh, good people, wonderful people. My heart was lifted up this morning. My heart was lifted up this morning, and I'm renewed. I'm new again. So I'd like you to stand up, Mom. This young lady reminded me that when she was new to what was going on 7 years ago, she was at a gathering in Richmond. She had with her a wonderful, wonderful baby girl. And I was so moved at the time that I provided from my heart to the heart of her daughter a name. And she came and she reminded me this morning, and she said, the baby girl is 7 years old now. And I went, wow, so powerful. So I wanted to introduce her because she lifted my heart up this morning, gave me new strength again. Thank you, Mom. Thank you for your goodness. Everybody, for a moment, stand up. Hold hands, please. I have to remember my manners. If my mom was here sitting in the back, she'd go, your manners, please. The great word in the Coast Salish language is Nutsamot. Nutsamot, my dear friends and relatives, simply means we are one. It's an action that I've been initiating for about 5 years now. For all human beings to be one. It's our oneness that provides us with the strength we need to do the jobs that we do. Happy to be here because it's about children. It's about children. And that's awesome to me because I have daughters, I have grandchildren, I've been blessed by my granddaughter to have 2 great-grandchildren. That's amazing to me. Your work with children in early childhood development is of the utmost importance because what you're going to do is you're going to help. You're going to help children be the best human beings that they can be. In squall the wind, Maminas, oh, Thihuam, Maminas, Huinam, Snow White, I'm asking all of our collective ancestors to come and be with us, to help open our hearts and our minds, as well to help us to listen. Huinamstam means to listen, to help us to listen to the Snowaya, the teachings that are going to happen here, so that you're stronger and we're all stronger. On behalf of all of the children from Musqueam, their families and their elected leadership, I welcome you here today to the unceded territory of the Musqueam people. What's most important to learning is having fun. So have fun while you're here. Have fun learning. Haitzapka siyam, haichka, haichka, haichka.
Shane, thank you so much. When working with the ASC, this is how we start our day. We start our day with a meal, we start our day with a circle, we open the circle, we open the day in the best way with the kind words, and make sure we move into it in the right place. Just a little bit of housekeeping for all of you to explain a little bit about what's happening here. This event is being live streamed, but also right now just me. So only the speakers will be live streamed, so none of you are on camera, so it's all good. If there are any questions, when the speaker's up here, if you have any questions, what we're going to ask the speaker to do is possibly repeat it back, but I'm also thinking I might be out on the floor myself and just see if I can say it a little bit louder. As you can tell, I don't really need a microphone. So with the Aboriginal Steering Committee, what I'm going to do is I'm going to ask all the members of the Aboriginal Steering Committee to please stand, so that we can recognize them. I'm not going to introduce them all. You're going to meet a few of us throughout the day. And where's Liza? Oh, Liza's back there. She is. These individuals here have dedicated themselves to this purpose of child protection and cultural safety. And we don't represent, we are from, okay, you go. We don't represent every nation in the province because we can't. We can only represent our knowledge and what we know. Okay, so people look and say, well, they're not from my nation, why would I have some? There's 36 language groupings in the province. That'd be a really, really large committee. So it's hard to operate that big. But we do invite people to join us and see what we do. We've had a really emotional couple of days this last little bit. We have a new member that just joined us. We have a return to the committee. And then we've had a couple of some baby news, so we've got those arrivals happening. But we also have news of a couple of departures. And that really rocks us because we become very close here. We become very attached to one another. The sharing that we do at the table isn't just solely around the work that we do. We find out what's happening in our lives, we share that. I've had a very, very emotional last 4 years, and I've had a tremendous amount of support, not only from the Aboriginal Steering Committee, but from the members of the help staff as well. Like I said before, we don't represent every nation in the province, but we do accept our responsibility as adults for the protection of every child. And that's really what we're here for. The group that we work with at HELP is fantastic. Remarkably resourceful, ridiculously intelligent. I spend a lot of my time thinking I'm so out of my league. But very open to our suggestions, to how we see things. We try to do everything that we do as gently as possible and say, well, how about this? I've got this information for you. I really want you to have this. So it's more about gifting and sharing. And we do that on a consistent basis. Just to give you an idea of where we are now, and having Kim lead that. I think Kim's our communication hub. She's the one that keeps us on track with everything that's happening. We get emails from her all the time. If we have any questions, we can call her. She'll look into it. And then, of course, Jess, being our elder. I'm 51 years old, and I don't make a move personally or professionally without the guidance of an elder. I have my mother, I have my Uncle Rennie, and I have Jesse on that list as well. And I think it's such a gift. We've had we've lost quite a few in my nation this last year, and it's losing just an unbelievably valuable resource. And so we're hoping that we can move forward in a good way and keep Jessie in our hearts and honor her by maintaining the way we operate, because she was such a big piece of that. So from here forward, we will introduce our first speaker. And I'll let
unlike Dwayne, I probably need the microphone for everybody to hear me. Sanesi Logan, Kinoas, Kinudikian. Good morning. My Haida name is Kinoas. I am the other co-chair along with Dwayne, and I have the honor of introducing our speaker today, Dr. Nell Lyman, who is the Chief Medical Officer, Senior Medical Officer at the First Nations Health Authority. And she is an Anishinaabe woman from Little Grand Rapids First Nation, Manitoba. She is Canada's first female Indigenous psychiatrist. She had her training at McMaster University in Hamilton. Before coming here to BC, she provided psychiatric services at Six Nations Medical Health Services based on Six Nations of the Grand River Territory. She's worked on several committees, advisories, and been involved in important research. Notably, she was on an advisory group on suicide prevention that developed a national framework for the Assembly of First Nations and addressing the issues of First Nations suicide. So I want to welcome and say hello for being with us this morning, Dr. Lyman.
Over here. Okay, sorry. Ani Buju, good morning. It's an honor to be here and spend some time with everybody this morning. Also an honor to be able to ask to speak on behalf of First Nations Health Authority. So you heard a little bit of my introduction. So my name is Nell, and I recently moved here to Vancouver in January, so I've just been living here for 3 months. You heard a little bit of my formal background. I'm a 60 scoop survivor, so I don't know a lot exactly my story, but I was in something like 4 or 5 different foster homes, and then I was a Crown Ward. Then I got adopted when I was about age 4. And sorry, I have a cold today. So I'm used to moving around, and I'm used to making my home in different places. And I lived in Toronto for about 12 years. After I left Six Nations, and now I've moved my family here with me to work on behalf of BC First Nations. So I just want to especially thank everybody here for such a warm welcome. I really enjoyed my time here in Vancouver so far, and aside from the occasional terrible driver that's tried to end my life crossing the street, it's all good. So it's really a pleasure for me to be here. So I'm here to talk about health wellness indicators, and particularly the First Nations Health Authority's approach to measuring aspects of child wellness. So I'm just gonna, I guess I just let people know when I want the next slide. All right, so part of what I'm here to do today is to share a little bit about the history and the development of First Nations Health Authority. So for those of you who aren't that familiar with First Nations Health Authority, it's a fairly new health authority that was established about 4 years or so ago, although I will show you later on in the presentation that it took a long time to get to where it's an actual entity as it's known today. And then discuss a major project that came out of the Office of the Chief Medical Officers in terms of developing a set of health indicators, health and wellness indicators related to First Nations child health. And how they did that using what's called a two-eyed seeing approach, based on the First Nations perspective of health and wellness. That is also sort of really the underpinning of what First Nations Health Authority bases its work on, and shifting these indicators from looking at, from taking a sickness approach or a disease approach into a more holistic wellness approach. And ultimately our work, and this work, is to improve the quality of health and wellness services delivered to First Nations. So next slide. So I'll tell you a little bit about who we are. And again, like I said, I've only been working for FNHA for about 3 months. So when there are questions, if they come up toward the end of the presentation, I'm also here with someone who's been at FNHA a little bit longer than I have, Ms. Krista Stelkaya, who is our Manager of Population and Public Health. She's sitting in the audience, so she's going to help me out as well. So FNHA is the first province-wide health authority of its kind in Canada, and it's by First Nations for First Nations, and that's a major difference as it's happened across the country. So those of you who may know of Health Canada and its previous iterations, the federal government, there was First Nations Inuit Health Branch, and eventually that got transferred. The Pacific region of First Nations and Inuit Health Branch got transferred into eventually what's become First Nations Health Authority. So that happened in 2013, and it was a very slow process, as I mentioned. So we aim to reform the way that healthcare is delivered to BC First Nations, closing the gaps in health disparity and improving health and wellness. Next slide. So we have an overarching vision, values, and directives. So, and I'm not going to go into too much detail. Some of these will come up as I go through my presentation. But our overall vision is healthy, self-determining, vibrant First Nations children, families, and communities. And we work alongside our values, things like excellence and fairness, respect. And the different directions are also what guide our work. And it's important to note that all of these, the vision, the values, and the directives all came from communities. So these aren't something that the leadership of FNHA just decided this is how we're going to work. This was all fed into from the communities on up. So we work for communities. Next slide. And we have developed a First Nations perspective on wellness. So this is the lens through which all of our work takes place. It's the BC First Nations perspective on health and wellness. It comes from our ancestors and is relational in nature. Colonization interrupted this worldview, and each of us is on our own health and wellness journey. And so as we have experienced historical events in the past, we now have, we're returning to our teachings and coming up with different ways to be more healthy. So this perspective, you'll see it a lot if you've had any relationships or partnerships with FNHA. This model really guides all of our work. And it's quite detailed, so I'll just give you a quick overview. But at the very center of the circle is each of us as individuals. So yeah?
I was wondering, could you give me your definition of First Nations?
Could I give you my definition of First Nations? So people who live in their, like, I'm not sure exactly what you're asking.
Well, what I'm wondering, like BC First Nations, and you're talking about community. So is that primarily on reserve, or are you looking at urban communities as well, and the Métis community, or is it just on reserve?
So we include First Nations people in the sense that they have roots in reserve communities, but they may live in urban centers, right? So they're people who are First Nations who live here in downtown Vancouver, but their roots are back with a certain community. And it does not, in this case, include the Inuit or Métis people, if that helps. So the very center of the circle is each of us as human beings, as individuals. And then we have the four aspects of ourselves, so the emotional, mental, physical, spiritual. And then we have ways that we interact with other people. So respect, we rely on knowledge, we have relationships with other people, and we have responsibilities, not just to ourselves, but to our families, our communities, our nations. And where health and wellness takes place, so places like within the family, on the land, within our communities. And then the last sort of outer circle before the people are the factors, the determinants that can impact upon our health and wellness. So things like social determinants of health, environment, economic and cultural factors. And then the last picture just includes that all of us are kind of in this together, right? It is relational. So we've included in this depiction people who are the children, who are small, people who are adults, people who are elders, perhaps people who have physical or other challenges. Next slide. So a lot of the times when, from my understanding, again because I'm new to FNHA, that when work is being done, we use graphic artists to sort of take these drawings while the work is taking place and sort of visually depict what's happening and the sort of summary or outcomes of meetings. So we have developed, there's a whole way of looking at health and wellness that's very different from just a strict Western medical model, which tends to look at things as, you know, symptoms or body parts or what we call disease, dis-ease. So there's a whole ecosystem of health and wellness, including, as also shown in the First Nations perspective on health and wellness, that health starts with us as individuals, and we at First Nations Health Authority also try to live by these principles. So for example, we are all on our own health and wellness journey. We are partners in health and wellness, and we can be health and wellness champions. So I heard, I can't remember, I was in a number of meetings yesterday and I heard there was an initiative where the various chiefs in the province of BC agreed to be health and wellness champions as part of an initiative in their community. So one of them might have, say, decided to start walking 10,000 steps a day on their Fitbit, and then they would document their journey on social media, so either Twitter or Facebook, something like that. So it's being examples for people in terms of doing things to look after one's own health. And that it really does go out from the individual to the family, community, nations or regions, and the overall province of British Columbia. Next page. So this is a quick diagram of the governance structure of First Nations Health Authority. So we are guided, we're here at the bottom, and we are guided in our work by forming a group of organizations. So for example, there's the First Nations Health Council, which is sort of gives us our political leadership, but very much separates politics from being able to deliver health in the way that FNHA does. There's the First Nations Health Directors Association. So these are all the health directors in communities across the province, and they provide technical advice and guidance to us on things like program and service development, delivery, and they are the folks who are really in their communities, so they know what's happening on the ground. And then the three, the Health Council, the Health Directors Association, First Nations Health Authority, combined with other government partners, federal, provincial, form the Tripartite Committee on First Nations Health, and that's so we work to live up to our commitments, and we are all partners. So the key here is that we are dependent on one another, we are interdependent, we are interconnected, and we try to provide excellent service programs and service delivery to our communities. Next slide. So this is a quote from Chief Ian Campbell, and I think it's important to know that First Nations Health Authority, when it came into existence, was really supported by the vast majority of chiefs across the province of BC. And so this is one quote as I think FNHA was forming. We are at a pivotal moment in our collective history, one where we have a unique opportunity to mature as a society. We are now entering a post-colonial era. This country is founded and built on a very solid foundation of Indigenous people. We will no longer be invisible in our own land. And I think that quotation speaks to the crux that we have always been self-determining, but because of the events of the past, that has been impacted. But we are now starting on a process and are in processes of being self-determining and having control over our own health and health services decision-making. Next slide. So this, I believe that every PowerPoint presentation should have a very, very in-depth, complicated slide. And, this is it. I don't pretend to understand every single thing on this slide, and our CEO, Joe Gallagher, those of you who know him, I was at a presentation about a month ago, and he literally spent an hour on this one slide. So he can give you a much better detailed summary of how FNHA came into being. But I think the point of this slide really is to show you that this took place over a long period of time. It took many, many years to where we are today. So First Nations Health Authority, as it exists, is about 4 years old. So we're a relatively new organization, and we've already, I think, been involved in a number, at least from the Office of the Chief Medical Officer, been involved in a number of very interesting projects. Next slide. So this is our office and our mandate, and the slide's cut off a little bit, but right now the picture on the right-hand side is Dr. Shannon McDonald, and she's our acting Chief Medical Officer right now, while Evan Adams is away on a leave. So she's our fearless leader for the moment. And we're thinking of her today because she's also suffering from this terrible cold that I seem to have as well. So we have a number of functions, very important functions within FNHA. So part of our role is to report on the health and wellness of the First Nations population in British Columbia. We lead different population health and wellness initiatives and innovations. We try to advance the quality of care that's provided to our people, for example, through complaints. We ensure appropriate data governance, and I think that's something that we'll probably spend a lot more time discussing as the day proceeds. Providing support to the regions, so the 5 different regions across the province. And we are starting to establish ourselves in what we call the watchman role or the watcher role. So my understanding, this is from Haida culture, where there are the 3 watchmen that sit on the roof of a building looking outwards, looking for risks or possible dangers for the community, and reporting to the community, or issuing warning to the community if there's some risk. And that's part of what our role is in the OCMO. So we try to integrate Indigenous stories, knowledge, health data, be responsible to community needs, and try to lead toward the best health and wellness outcomes for First Nations people in British Columbia. And on that way, the OCMO is really starting to develop over time. So there are a number of physicians who have been added to the office, myself included. So as was mentioned in my introduction, I'm a psychiatrist by training, and I've worked as a psychiatrist for about 20 years. And I came to BC to assume sort of the portfolio, if you'll call it, in the area of mental health and wellness. We have other physicians that work other amounts of time for FNHA. So there's already Shannon McDonald I mentioned. There's Dr. Helena Swinkles is the acting Deputy Chief Medical Officer. There's a Dr. Sean Wachtel who works for us 0.5 or 50% of the time. His primary role is in primary care. There is Dr. Kelsey Louie, who's based on Vancouver Island, who has a number of different initiatives in his portfolio, including primary care as well. Dr. Anjali Malhotra works for us 1 day a week, and her interest is in women's health, particularly in screening for various conditions. And Dr. Robert Fox works for us just over half a day a week, and he just finished fellowship in addictions training. So all of us were sort of a fairly diverse group within the OCMO, but over time we hope to be able to partner and be involved in more projects that are happening not just in Vancouver or this region, but across the province. Next slide. So as I mentioned, one of the real shifts I think that FNHA, the OCMO, and others have tried to make is the shift from viewing ourselves from a sense of sickness more into wellness, and taking a more strengths-based approach. Probably those of us who have been around for a while and are familiar with Indigenous health research, you know, years ago there was studies would get published that were particularly sort of, you know, sort of the bad news, how we compare to the general Canadian population, for example, what deficits we have. Sometimes this research could be very harmful to communities and very stigmatizing for communities. So that's one thing nowadays that we're aiming to very much avoid, and shift it more into a health and wellness focus. And also sharing our strength and resilience. So there are examples, there are examples in this province, for example, where there are communities that are doing very well, have a lot of strengths, a lot of resilience. And it was the same when I worked in Ontario at Six Nations of the Grand River. They had a lot of capacity and strengths in that community. And it's a responsibility, I think, to communities that may be struggling for us to share that knowledge in order to help other communities out. So we want to be able to build, share success stories. And two-eyed seeing is something that the phrase is used a lot more over the last couple of years. And it's particularly meaningful to me as a Western-trained physician. So the little bit that, for example, I mentioned I was a 60s scoop survivor, so a little bit that I do know about my birth family is that I come from a line of traditional healers on my mother's side, but I had no contact with my birth family. So I think one of the reasons, and this isn't scientifically proven obviously, is that one of the ways that I have been able to express my desire and my want to be able to be helpful to people was to go into medicine and particularly trained as a psychiatrist, because psychiatry lends itself very well to an oral tradition and storytelling. I've always loved to hear people's stories, and I like to tell a few of my own as well. And psychiatry is difficult because you have to be able to have an ability to connect with someone in a trusting way, in a respectful way, and do it fairly rapidly in today's medical system. And that's really something that can't easily be taught. And I always felt so fortunate that I was able to reach people fairly quickly in a lot of cases and be able to be helpful to them. And so two-eyed seeing is learning how to see from one eye with the strengths of Indigenous knowledge and ways of knowing, and with the other eye, the strengths of Western knowledge and ways of knowing, and learning to use both these eyes together for the benefit of all. And my experience so far in Vancouver, I've had a chance to go to a number of gatherings with Indigenous medical students, residents, physicians, and people who support us and work with us. And I think that that two-eyed seeing is definitely part of how we work, right? So we are Indigenous people who happen to be trained as Western healthcare providers, but we use it to offer the best of both worlds to our people, if that's what they choose. So a major part of what I want to share with you is the importance of developing good working partnerships. That's a lot of what the Office of the Chief Medical Office is about, and a lot of what FNHA is about, is establishing partnerships. And you know, given our history of colonization, historical experiences, etc., sometimes those partnerships aren't easy, but they're necessary, and we need to be equal partners now. The days of where we were told what would happen or what to do are kind of over, and the same is true for research. The days of someone traveling into a community, asking a whole bunch of intrusive questions or taking biological samples and disappearing, never to be heard from again, those days are kind of over. So partnerships are crucial, and we talk a lot about it, and we spend a lot of time investing in partnerships. So one of our major partnerships is with the Provincial Health Office, the Provincial Health Authority. And this is the office of the Provincial Health Officer, and this is our current Chief Officer, is Bonnie Henry, and then there's another picture of Shannon McDonald. And this partnership has gone on for a number of years. Next slide. So one of the major projects that has happened was about 2 years ago when we started working on this health indicators. There was a meeting about 2 years ago where people came together from the Office of the Chief Medical Officer and from the Provincial Health Officer, and they had a workshop and talked about how we could work together and partner. Next slide. And so we also talk about having good data and how important that is for health and well-being. And this is a quote from Gwen Phillips, who is the First Nations Information Governance Center board member and a member of the First Nations Health Council. Data governance is a foundation of nation rebuilding. Our leaders work hard to promote positive change, and they need access to data to show how well their community is doing in areas such as health and education. When we have good data, we make good decisions. We can build sound plans and make good investments, and this is good governance. And so I think, you know, there's probably a lot more discussion we can have about, you know, what is good data and how good data is collected. And as I already kind of alluded to, there have been times in history, particularly in doing health research or research with Indigenous communities, that this relationship between researchers and communities has been pretty, there have been some negative impacts from it. And even years ago, as much as maybe 15 or 18 years ago, there was a particularly egregious example of health research that involved the New Chalmers Nation. And so we don't want to repeat those types of episodes now in the future. But we do, in order to make decisions, not just around program development and program delivery, but in terms of making policy changes, systemic changes, we need to make decisions based on what we call good data. But that's through a health research partnership that's equal. Next slide. So originally, this work has taken place over the past 10 years or so. There were 7 health indicators that have been tracked over time, and the Office of the Chief Medical Officer has been reporting on them. The first 7 indicators were things such as infant mortality, children with a healthy body mass index, youth suicide rates, prevalence of diabetes, mortality rates, life expectancy, and the number of practicing First Nations healthcare professionals or providers. So those were the initial 7. The final report, as this 10-year cycle has come to an end, is due out in the next couple of months. Next slide. So the work that has happened more recently over the past 2 years is all in support of FNHA's overall vision, as I mentioned before: healthy, self-determining, vibrant First Nations children, families, communities. So we have been in a process of developing 15 new health indicators, as I mentioned, that are shifting more from disease or outcomes into wellness indicators. And these will be added to the 7 original indicators measured and reported on for the next 10 years. And I believe that the first report on the new set, combined set of 22 indicators, is coming out in 2019. Next. So how this all happened initially was there were, a number of indicators were kind of thought about, brought to the community level, the regional level, and then there was this widespread kind of like sort of free thinking where they came up with many, many different indicators. There were 192 community representatives, and participants provided a number of suggestions, and these were, I think, dozens and dozens of potential indicators. So this is again a process where instead of sort of, FNHA or the provincial health officer just saying, well, these are what we're going to measure, there was actually kind of from the community flowing upward ideas about which indicators would be best to measure child health. And so the final list came back up to the level of the PHO and the FNHA to narrow down the list. And as I mentioned earlier, so 15 new indicators have been in place. And again, I'm sorry that the printing is so small on this slide, but some of the example indicators now are things like education, aspects of cultural wellness, including exposure to traditional language, knowledge of and access to traditional foods, access to traditional medicine, healing, importance of spirituality, ecological health, experience of cultural safety and humility in receiving health services. So different indicators like that. I won't go through all 15 of them, but as you see, it's sort of an expanded model with a shifted focus into wellness. Next slide. So the principles used in developing the indicator framework also give us some guidance in terms of where to look for quality improvement and where to possibly identify places in the systems, different health systems, where changes can be made. And this again leads us into one of the indicators that I mentioned were around aspects of cultural safety and humility. And many of you have probably heard these terms over the last number of years about developing here in British Columbia a framework for cultural safety and cultural humility. Next slide. So just briefly to summarize for people who may not be as familiar, So cultural humility is a process of self-reflection to understand personal and systemic biases, to develop and maintain respectful processes and relationships based on mutual trust. Cultural humility involves humbling, acknowledging oneself as a learner when it comes to understanding another's experience. And cultural safety, related, is an outcome engagement that recognizes and strives to address power imbalances inherent in the healthcare system. It results in an environment free of racism and discrimination, where people feel safe when receiving health care. So these are new, relatively new. Actually, they're not that new. The term cultural safety actually originated in New Zealand. It came out of the nursing literature. I think it was like 20 years ago or something now, but has slowly been talked about in Canada and the different provinces and regions over the last number of years. And why it's so important to have these aspects in place, not just in health systems, but within each of us who may play a role in the healthcare system, myself as a physician, for example, is because we know historically First Nations and other Indigenous people have been maltreated in the healthcare system, sometimes to the point where it has cost them their life. So everyone's been familiar, probably heard about the case of Brian Sinclair in the emergency room, who presented with a very treatable urinary tract infection. When he wheeled himself in his wheelchair into the waiting room, people just assumed that he was another drunk Indian, excuse the phrase, and they left him there for over 30 hours without even registering him or doing any kind of intervention. And he died in that waiting room, and his dead body was not discovered for several hours, despite several people in the waiting room going to the nursing station and saying, this fellow seems to need some help. So that's like probably one of the worst examples of someone who has not received culturally safe care in any way. And there have been others. So we always have to be mindful that this is something that we really want to be part of the healthcare system, because when people come forward, if they finally overcome, because of all the history, when they finally come forward to seek help and have access to help, we don't want people receiving terrible or negative care. Next slide. So one of the things that FNHA has done is we have started to work with different organizations to start with the different various and many health regulatory bodies across the province to sign a declaration of commitment to culturally safe care, or cultural safety. And so this is a process that's ongoing, and there are other organizations that we are hoping eventually over time to also sign this declaration with us. This is a quote, I can't really read the printing at the bottom, but it was from a community member, their own description of what cultural humility means to them. I believe you understand what you think I said, but I'm not sure you realize that what you heard is not what I meant. And so I think a lot of the times we as healthcare providers, we get so caught up in our own agenda that we don't have the cultural humility to take that time and pause, think about where we're positioned in working with someone, where that person might be coming from in order to hear them. I know there have been different studies, and I don't know the numbers exactly, someone can correct me, but I know they've done studies of family physicians of how long, when your family doctor comes into the room and says, what brought you here today? And you start going, well, Dr. So-and-so, I've got this. And I think it's like only several seconds before the doctor cuts you off and launches into their own kind of agenda. So that's part of what we're talking about, is to be able to understand differences between people. So as I mentioned, there have been a number of associations, health regulatory associations, 23, have signed this declaration. Next slide. So there have been organizations, the Ministry of Health, the 5 regional health authorities, the provincial health authority, and the different colleges, so things like the College of Physicians and Surgeons, College of Dentists, Dental Hygienists, all the sort of different health professions. Their regulatory colleges have signed on. One of the ways that we want to take this even further here in British Columbia is have different other health system associations join on and academic institutions. So for example, UBC, Simon Fraser University, where we partner quite a bit. One of the initiatives that I've been involved in since I started working at FNHA is the British Columbia Centre on Substance Use. And they're a relatively new organization themselves, but I've been very peripherally involved at the level of the Chief Medical Office and different research projects that are going on. And hopefully as time goes by and we develop that partnership, they can be a signatory as well. Next slide. So there are on our website, of those of you who haven't ever been to our website, it is full, chock-a-block with resources. So there's this document called Creating a Climate for Change that deals with cultural safety and humility and talks about the vision that we have so that people, BC First Nations people, have a new relationship with their healthcare providers based on mutual respect, understanding, and reciprocal accountability. And these are, if you've been at different conferences or gatherings, you've seen probably we have a booth at the recent FNHA Mental Health and Mental Wellness Summit that took place, I think it was in February. We had a booth where people could sign their own individual commitments to cultural safety and humility. And then you can post it on social media with the hashtag It Starts With Me. I remember this in February because they were promising free yoga mat carrier bags to people. So even though my initial motivation was to secure a yoga mat bag, I obviously got on board with the whole notion of culture and humility. But people, as you see, it's really important. It's so important for our people. And we ourselves eventually become patients ourselves, right, at some point in our life. So we want others to be treated the way that we are treated. So I'm going to just take you through one last example of a partnership that has implications for health and wellness. And initially, when we were putting this presentation together, Chris and I were debating whether or not to talk about this or not, because when you read things like BC Coroner Service and Death Review, you think, oh my goodness, like what does this have to do with, say, the health of children and youth? But this is an example of how we have moved away from sort of skewed reporting, disparities, deficits, into a strengths-based, more affirming way of looking at data. So we do know, for example, that injuries are one of the leading causes of death amongst First Nations people, particularly our youth. And so about a year and a half ago, a partnership was formed between the BC Coroner Services and FNHA to form a panel and conduct a review of deaths of young people that were unexpected. And this is a copy of the report on the left-hand side that you can access through our website as a PDF. So the review panel was appointed and comprised of various professionals, First Nations individuals with expertise in areas like Indigenous health, injury prevention, child welfare, public health, education, law enforcement, and academia. And as I mentioned, the purpose of the panel was to examine the unexpected deaths of First Nations youth and young adults 15 to 24 years old over a 5-year period, or 6-year period. And so what ended up happening as a result of this review and the partnership that had been formed was the panel came up with 4 recommendations. One of them was to promote connectedness to peers, family, community, and culture. One recommendation was to reduce barriers and increase access to services. The third was to promote cultural safety and humility and trauma-informed practice. And the fourth was to elicit feedback through community engagement. And the unique thing about how this review and partnership took place and the work happened was the recommendations were made to specific organizations. So it wasn't just that you see here on the left. So it wasn't just that, you know, we put out these recommendations like, oh, I think it would be better if, and there's really no accountability. So, you know, at FNHA, we are accountable to our communities all the time. And so when you establish that accountability, then hopefully work will happen in that way that will move things forward. So the same can be said for the health indicator work or any other kind of future health-related research and work that we want to take place, that there is this mutual trust and respect in forming the partnership, but mutual accountability and accountability to communities moving forward. So I just want to kind of sum everything up. I think, as I've already just said, from my short time at FNHA, one thing that I have become very well aware of is how seriously FNHA takes its relationship and responsibility to communities. And in terms of conducting health research related to First Nations in BC, and all of our work in general, sort of a slogan or a saying that I've heard over and over again is nothing about us without us. And that speaks to sort of the way that research was conducted in the past and the way that it's going to be conducted is currently conducting in the present. Using that two-eyed seeing approach, so the best of both worlds. And this translates not just into research, but also translates into all sorts of other work that we might be involved in. So one of the projects that I've recently gotten more involved in through my partnership with BCCSU is they just came out with national opioid use disorder guidelines. Now we're working on alcohol use disorder guidelines. And so there's a way of, when guidelines are devised, they use levels of evidence. Their evidence is kind of graded. And it's typically on a very Western medical model scale that's used. So for example, you know, the best level of evidence is a randomized control trial where sort of you and me, we both take a medication, but we don't know which is which. And then after a period of time, we switch. And then you measure at the end and you go, oh, this was better, this was worse. We need to, in the formulation of not just health research projects, but things like forming guiding guidelines, have a respect also for Indigenous knowledge, Indigenous ways of knowing, what we think is helpful in terms of helping our folks who struggle or are challenged with different issues like substance use problems. And that's just as important, that knowledge. Our way of evaluating evidence or whether something's helpful or not is just as valid as a Western lens. And as I mentioned, I've stressed, I think, a lot, it takes a lot of time to form partnerships and nourish partnerships based on mutual trust and respect. But ultimately, it's because it's on behalf of our people. And collaboration is part of a good partnership as well. So I just included two quotations toward the end, and I think it speaks to sort of what I've been saying this morning. We gather knowledge both by generating new knowledge and collecting existing knowledge. We manage knowledge through sharing and protecting it. To support appropriate ways of gathering and managing knowledge that helps leaders and planners strengthen the health and wellness of BC First Nations. So I think that's kind of what we're all here interested in and talking about today, is how we can use a tool like conducting research to ultimately impact upon the health and well-being, wellness of our children, our families, and our communities. So I just want to thank you. And I guess the last thing I'll say, I hear a lot as I've been to different meetings over a number of years. I always hear the saying, our children are our future. But one thing I heard this morning in the openings that made me think of it, and I've said this in different presentations too, is, you know, yes, our children are our future, but our children are our present right now. And they deserve the best chance in life that we can offer them. So all of the work that everyone here does is very important because we all have that goal in mind, right? Keeping our children now and our future children well into the future. So I want to thank you very much today.
Just on behalf of the HELP and the Aboriginal Steering Committee and everybody else here in attendance, we just like to thank Dr. Wyman for presenting here today, and a small token of our appreciation. Thank you. Do we have any questions?
Does the FNHA operate with specifically towards the research question? Do you operate by OCAP principles, and who has access to that research and data? I know you're putting out reports soon, and that there's some references earlier in the presentation about some of the different areas that you're tracking, but I'm curious to know, because OCAP is becoming a bigger and more accepted approach, especially when it comes to reconciliation. You guys are First Nations and Aboriginal organizations, so I'm curious to know, do you follow OCAP principles, and how might be better directed at colleagues?
Yeah. So the question, just for the people that are on the webinar, are around whether or not FNHA works with the OCAP principles. And I think I'll give the short answer, yes. And what I'll do is maybe ask some of my research colleagues from FNHA to maybe talk about that just a little bit for you. So maybe David or Krista. So this is Krista Stelkia, who's our Manager of Population and Public Health at UCMO.
Hi everyone. So in terms, it's a really great question in terms of if we're following OCAP. And so I think in terms of implementing OCAP from an organizational perspective, we're still having ongoing discussions on how to do that. But when we engage on different research projects with, you know, external researchers, internal researchers, we always build into kind of the governance piece, like how are we going to make sure that community owns this data? How do we protect this data to make sure that external researchers who won't use it for unintended purposes? So we're very protective of the data when working with community. And so I think a really good example of this that I could give really quickly is in terms of a trauma-informed care grant that we were successful in receiving. So we heard from elders in the New Channel Nation that they weren't accessing services from Port Alberni because of trauma that they were receiving in the hospital. And so as a research team, we came together and we developed a grant to engage with elders. How do we transform their experience? How do we get them to go to the hospital? And so we conducted a workshop that was 2 days, and the outcome of that was really how do we identify a good way moving forward. And so right now we're at the stage of we have the data, and our priority is really to present to the community first. And so we're actively working on kind of identifying community as a priority as opposed to a typical academic approach, which is publication or presentation. So I don't know if that really addresses your question, but I'm always open for chatting further.
Are there any other questions?
I'm curious to know about evaluating the recommendations to the different ministries and organizations, and about how is the response to some of those, because we have organizations like the Representative for Children and Youth who can make recommendations, but they're not enforceable. So I'm curious to know, was there an evaluation, are you monitoring, and has there been an inverse relation to the improvements based on the recommendations that you made? Like, are you, I guess it's more of a meta-analysis of the work that you've done, making to the recommendations.
Are you specifically talking about the coroners, the work with the BC Coroner Service?
I think it was one of those times where you had 4 different areas where you presented to MCFE.
Yeah, sure. So I can speak to that. So the really great thing about that particular partnership is that the recommendations were addressed to specific organizations, each with so those were broad ones with very smaller recommendations underneath. And so once that was released in November 15, 2007, so just this last November, each organization had, I believe it was 90 days to develop an action plan of how they're actively going to be addressing these. And so there was that accountability piece in terms of saying, here's the recommendations, how are you going to achieve this? And you have 90 days to develop a plan. And so on the FNHA side, I led the development of our key recommendations. We developed an action plan and submitted it to BC Corners, and my organization, along with others, posted that on the BC Corners website. And so there were a couple of recommendations that, for some of the organizations who they were addressed to, it kind of forces them to elaborate more or collaborate more with some other organizations, which it's actually very hard to make organizations sometimes work together on specific topics. And so now that everyone has kind of identified their areas of action, they have certain key dates that they must meet those targets. And so it's a really good demonstration of kind of putting out recommendations and then making these organizations accountable in a very public-facing manner. And so I think from our perspective, it was a really good way of trying to open up the discussion and make it a bit more accountable in terms of our key partners.
Right now, what is the relationship look like between FNHA broadly and like a local healthcare provider? And in the future, like, what's your ideal business relationship?
Well, I think, at least to start to answer your question, like right now, FNHA isn't necessarily a direct clinical care provider, aside from a few exceptions of the nursing stations, very few nursing stations. And I don't, I can't speak on behalf of FNHA's sort of future intentions, but from what I understand, being a member of the Chief Medical Officer's office, is that that really isn't a plan, anyway, for the near future. But we do, obviously provide sort of guidance and leadership and listen to the people who work in the community. So for example, since I've been at FNHA, I've had quite a number of nurses with the nursing leadership who are in touch with what's happening in the various nursing stations across the province in terms of what's going on, what some of the critical issues are. And we provide some advice and guidance in that form, but in terms of providing direct clinical services, we don't. The physicians that work for FNHA don't as yet. I don't know if that answers your question.
That's like half of it, and I guess the other half would be in terms of helping you with data collection or helping you in putting messages out to the community. Is there a relationship between you there?
That's a really good suggestion. I mean, because of my time here has been so short, sometimes I feel like I can't appropriately answer questions, but I think one of the ways that I think we keep in touch, at least with some relationships with our physician peers, is through different, like for example, I'm terrible at the names of organizations, but it's the specialist organization here in BC, and I'm supposed to be sitting in on the meetings of those teleconferences. But I think that's an example of a partnership that we probably could do a lot more work on advancing further, right? So yeah, I mean, that's a great suggestion. I don't know what Evan, yeah.
Yeah. I used to live in the island,
influences that FNHA had on island health, both north and south, is that they hired cultural safety facilitators. And when I think of the timing of the 4 years, it certainly was about 3 years ago that Marty Eagle and another woman, Indigenous woman, were hired on the island. And so I experienced that influence in our community, which I directly related. Maybe there wasn't a direct contact in saying you should do it, but I think it was an exact timing of the influence you had in the work that you were doing in health. And I think it's expanding to other communities. Ours was almost like a pilot.
Yeah, I think depending on different initiatives, there have been initiatives like what we used to, in Ontario, we call them patient navigators or family health navigators. And I think related to the opioid response, something called community action teams, which will be much more kind of practical, almost assertive community treatment like to help people and improve cultural safety. Yeah. Any other questions?
So thank you, Dr. Wyman, for that presentation. I'm always really excited when I hear people talk about humility. I think humility is our strongest virtue. I think humility, the understanding around humility that I have is that the universe has many messages for you. Humility will open up to them, to embrace them, to accept them. When I work with young people, I tell them everything's out there for you. You just got to go out there and get it. But you still have to have humility to recognize and accept it. So we're ready for break time. We're going to have our next speakers come up at 11:15. I will be walking around the room, getting everybody back to their seats. You did see the members of the Aboriginal Steering Committee stand earlier. I encourage you to go up, introduce yourself, tell them what you do, ask them what they do, and you'll get to experience the levels of diversity that we embrace at the Aboriginal Steering Committee. 11:15. Thank you. Okay, so we're going to present our second speaker for the morning. This is my brother, Dr. Martin Good. Martin works at HELP, and he's going to talk to you about child well-being. This is how close we've become because Martin came in, and because he cares for me so much, and he's got a little bit of sickness in his house, he wouldn't embrace me. Yeah, I wouldn't have anything to do with that, so I got my hug. All right. So, everybody, Dr. Martin Good.
Thank you, Dwayne, brother Card. Yeah, it feels really awkward to walk into the room and not hug people. I'm feeling okay, but both Anna Gatto, my wife, and Luisa, they went sick. They came down sick last night, so I'm just hyper careful to not spread it on. And so I'll give the presentation by myself. Originally it was planned to have Anna and myself talk about different sections, so I'll try to cover her sections as good as I can. Speaking of hugs and thinking of the morning, so Jessie, I'm looking at you, so I will miss your hugs for sure. Not only those, I'll miss your gentle, soft-spoken manner of, pulling me aside after I would say a few words and teach me things and give me further insights. And so because one of the themes today has been two-eyed seeing, I'll touch on some of the history that relates to two-eyed seeing and how we've worked with ASC and other partners to learn about the concept and hopefully move it forward. And of course I'll also talk about, as Dr. Nell Wyman said, I'll talk about data on child well-being and indicator system, and specifically how we come up with good data, meaningful data that we can use to make a difference for children and families, and of course then the fundamental question is what type of data do make a difference in the lives of children. So yeah, that's the title of the talk, Child Wellbeing, What Differences Make a Difference. And you'll see there will be quite a few parallels between the vision and the goals for the indicator system that we just heard about from Dr. Wyman with the FNHA, and some of the things that we have been trying to do. And of course, one of the purposes is to see where the complementary alignment is between what we're doing and how we can further collaborations in our complementary thinking and integrate it over time to make it even more powerful and more useful for supporting children with families with young children. So I have a clicker. So stepping into this room with this group, of course, I always have to think of Clyde Hertzman. So thinking of the vision and the mission we were pursuing in the work certainly that I am doing, but I think many of us are doing. I often think back of what he has meant for the work that is taking place at HELP, and thinking back of the history of doing this together with the ASC. He passed away 5 years ago, too early, but stays with us whenever we do the work we're doing. So the vision that we're pursuing is to make sure that all children are thriving in healthy societies, and our mission is that we're dedicated to improving the health and well-being of children through interdisciplinary research and mobilizing knowledge. So there are a few things in here. The goal is that children are thriving in healthy societies, and then what part can we contribute? So we can think about data, and you saw the quote by Gwen Phillips, I'll come back to that. And what is good data that can create leverage for decision makers to make decisions? And then what kind of research do we have to do across disciplines to make meaning of data, to come at it with the best knowledge we currently have? And then it's not enough to just create new knowledge, we have to mobilize it. And Mike, you asked earlier, how can we collaborate and think about knowledge mobilization, knowledge dissemination? How do we get the knowledge into the right spot so we can actually use it for doing good things as opposed for having it sit in data repositories or on shelves? So I'll talk about the vision and goals for our own Child Wellbeing indicator system, and while I do this, I'll reflect on some of the memories or anecdotes or stepping stones and having worked with these different data collection tools and having thought about them critically and collectively, and how can we make the data that we already have more meaningful, especially in the First Nations or regional context, and how can we think about collecting data that we don't yet have and ask the right questions so that we complement the existing data with meaningful data to make even better and more informed policy decisions in the future. So here's a quote that Mel Wyman read earlier by Gwen Phillips. So I acknowledge taking the slides from that slide set that was shared by the FNHA with us before and in preparation for this talk. And so you already heard the key question is, how do we collect not just only data but good data in order to make good decisions in our governance? And of course that's an overarching question whenever we think about the data collection initiatives we are. And one of our flagship projects has been to collect data at the population level about children's well-being in the context. So we are constantly confronted with the question, how can we actually collect good, meaningful, full data? So a very strong parallel between what Gwen Phillips sees when she talks about data and what you're trying to do with the data of the FNHA and how we look at our monitoring system. The evidence clearly says that the early years are fundamental for lifelong health and well-being. So in order to understand children's well-being over the life course, of course you have to start ideally as early as you can. So in our case, you see that on the graphic we look at everything starting at birth, or ideally preconception, or and then in the long term you would think about this intergenerationally, and then follow children over time to understand what kind of influences early on make a difference over a child's life course. One of the flagship projects we have been using in collaboration with multiple ministries. We have been using the Early Development Instrument. Many of you may have seen the maps that we have created based on the data collected on early children's health and well-being outcomes. So the data is collected by teachers through the school system during the kindergarten year. So when teachers have gotten to know their children for about half a year, they rate the children on different domains, in the physical domain, social, emotional domain, physical domain, communication skills, and all that data is then aggregated by help. And in collaboration with the ministries, we put these data together in maps at the neighborhood level so that we can look at the variability and child well-being outcomes that we see across the province. One thing, thinking about social determinant perspective when we think about children, child well-being and health, is that one of the biggest influence or one of the biggest challenges in regard to children's health and well-being in this province is child poverty. I'm not saying it's the only one, and it's not the only mechanism, but we have a poverty rate of about 20% child poverty rate, and of course that varies widely depending on which demographic or subpopulation you're looking at. And it's one of the greatest challenges in terms of connecting children to positive experiences and good resources in our society. Despite the fact that overall there's a lot of wealth and of course a lot of richness in the society, it's quite embarrassing, I guess, at a societal level that we're facing such a high poverty rate overall. So one of the examples of two-eyed seeing is the EDI was taken by help from the Offord Centre. So that was a group in Ontario that put together a survey, and then Clyde was the one who championed it here in the BC context, and the ministries jumped on the opportunity and supported it, and so we have collected data for 15 years so we can see trends over time. But one thing that opened our eyes in regard to looking at and understanding data in regard to Aboriginal children had to do with the question that has to do with Aboriginal status. So on the EDI, there's a question called, is this child Aboriginal? Yes, no, or don't know. And up until 2008 or 9, the recognition rate of Aboriginal languages in the province was lower than 1%. So in other words, when teachers reported on the different language backgrounds on the EDI, for all the different children, there was a fairly good pickup rate for foreign languages such as Mandarin or Punjabi, but the Aboriginal languages did not show up. So in collaboration with the ASC, and I'm not going into too much depth, and others have longer presentations on this, but in collaboration with the ASC, there was an additional question added to this, and there was additional training happening. Thank you. Is this the, So the original question asked about being Aboriginal, yes or no, and in the follow-up version, starting in 2012, after consultation with the Aboriginal Steering Committee, we included a question that now asks about children's language identity. And so the question now says, which Aboriginal language groups does this student identify with? Then you can actually click on a map, and you get all the different language group names on a geographical map. And you have a drop-down menu where you can actually click on the different names. And it prompted, also the training changed with the teachers. So following this change on the questionnaire and the training and the process of collecting data, the recognition rates of languages just skyrocketed. So it was lower than 1% before 2008-9. Then with some training changes, it started to improve a little, but the real change we started seeing in 2012-13 onwards. From that time onwards, there was higher than 50% recognition rates due to the change in questions that was based on the collaboration and trying to make more meaning or changing the way we collect our EDI data. And another interesting finding was the diversity of languages that showed up through the data collection, so that had not been seen in the data before. So that was quite validating in terms of the work, engaging this process and uncovering or discovering the diversity of languages that are spoken or with which children are associated in this province. So the EDI at the end of the day is a measure that really just looks at children's outcomes, child well-being outcomes, but we don't really have any context information that we're collecting. Up to that point, we did not have any context information that we were collecting with the EDI or any other measures. So what was developed at the time was the middle years development instrument, which is a tool that's not filled out by teachers but by students. Okay. I have to say, this makes me just a little sip of water. Hopefully, apologies. This is the MDI. It was developed based on the recognition that we don't really have any information on children's social and emotional well-being once they enter the school system. We, of course, collect academic information. For them, we also don't have good contextual information on what children do in school or after school, what are their day-to-day experiences. So the MBI was really developed, and it's really strengths-based, linked to health and well-being outcomes, to success and social and emotional development, both inside and outside of the school. So another parallel to what Nell Wyman described earlier, not just looking at the negative side and vulnerabilities of outcomes, but also looking at the positive sides and to see how we can build on this. It aligns with the rights of the child, so according to the convention which was endorsed by Canada, children have a right to give their opinion and be listened to by the adults around them. So they do that on the MDI survey. It's done with grade 4 and grade 7 students in school districts that participate universally, and they report on different aspects of their well-being. So we have a sense of whether children are thriving or whether they're not thriving. So we ask them questions about their life satisfaction, their health, optimism, self-esteem, and their sadness, and then can categorize these scores into 3 different categories, including the thriving category. And we also talk about different assets they have in their social environments. Do they have strong connectedness with adults around them, with peers? Do they experience positive after-school experiences? And do they engage in healthy nutrition and sleep experience on a regular basis? One question also related to Aboriginal identification, and again this was based on collaboration with the ASC and other partners in this work. So the question now reads, are you Aboriginal, no, yes, or part? And then the children are asked to specify more specifically whether they consider themselves Inuit, Métis, or First Nations. And this is actually a quote from Jesse talking or reflecting on the MDI at the time. And not just on the original question, but on this notion of giving children a voice on their well-being and social context overall, saying this gives us a positive perspective, a strength-based tool that helps us look at positive things that are happening and build upon those. And you can help to support children to continue on in that positive way, so they can again thrive and flourish. So I think there was a natural, I think that captures what a lot of people felt, that if you ask children directly in terms of what they have and what they need, it gives us a different perspective on how we can think about supporting children and the context around them. So on the MDI, there's some further explanation on Aboriginal identification. So for those students who wish to have further information, they can find that information on the whether filling it out. And then we also asked them whether they actually learned one of the Aboriginal languages. So we asked every child which language they learned at home and which language they speak at home. And then we specified on the questionnaire different categories, and the first one is Aboriginal language, and then we ask if the children do check that they please identify which language group it is they identify with. And again, as with the EDI, we have seen great success in terms of capturing a fair amount of children who indicate yes, that they do associate with the First Nations language. Many of the children do not specify the language, maybe partially because they may not have learned Welsh, but there are high numbers for Métis and Cree, Inuit, Haida, and so forth. And again, quite a large diversity of different languages that come up. And Apart from looking at the language background, some of the core questions have to do with how children rate their own well-being. And one of the scales that we're using is the satisfaction with life scale, which in essence asks children whether they're happy with their life. And one thing I'll walk you through, and this is a study that Anne Galaman conducted during her PhD, is to explain a bit why, whether the MDI gives us, according to the evidence, valid information on how children are feeling. Because a lot of pushback we got from the public when we started the MDI was people asking, can children actually give you meaningful information when they're 9 years old or 12 years old, which is when we're collecting these data. So Anna engaged in these cognitive interviews during which you're basically asking children, what are you thinking and saying to yourself when responding to the questions. So she would present the children with these questions and they would say, yes, I'm very happy, I'm not very happy, and then she would ask them to explain, why did you just say what you responded to this question. And I'll just walk you through a few examples to give you a sense that they can very, very completely and very meaningfully exactly explain to you why they're feeling happy or why they're not feeling happy. And in fact, the responses they gave to us are almost identical to what parents would respond to the same type of questionnaire. So the validity evidence for what we have received for the MDI has been very, very solid and confirming the theories that we had beforehand about children's well-being. So speaking of good data, we think we have good evidence for the MDI that the children are actually reporting on something that has true reflection in the experience and social context that they're experiencing. So some of the themes that came up very predominantly were social relationships, feeling connected to people in their social environments, primarily to their family. And I'll just share a few quotes to get a sense of the answers that children gave. Here's one: I'm happy with my life because I have a really caring family. And like my mom is always there for me whenever I'm sad or there's something that I really want to tell her. So family came up as probably the most prominent topic when children describe their well-being, followed by relationships to peers. Here's a quote: my friends, they're very supportive of me and they're wonderful. People talk about their personal characteristics. I've got these good talents in singing and a lot of knowledge too. And they talked about things that make them not feel well or unhappy. So in this particular case, a child said, because I'm not doing that good in school. So I think I see some nodding in the room, so we can all easily relate to these. So there's nothing that is invalid about these answers or what is shown here. They also talk about possessions. We're not living in poverty, and that's also important. I have shelter and all the other basics like water. And they also talk about technological gadgets. I'm not sure how to pronounce this thing. And bigger house and a car. So I guess some focus on the basics, others more on I'm not sure I guess luxury items. And then use of time. We have quite a few questions on the MDI that cover whether children engage in after-school activities having to do with sports or free time playing with their friends and so forth. And that's what also came out in the responses. Children like to play, especially when they're with their friends. And here's a quote: because most of the time I like to play. So that child responded that he was happy. So general feedback. So apart from validating the question, children also told us that they think it's very important to engage in this kind of data collection. One quote talks about the overall the importance of asking them about their feeling. I think you should know what's going on in their heads or in our children's heads, because a lot of kids have problems and they don't talk about it, so you need to know this stuff. So bringing up things that they're reflecting on. To get information that would be important to help children, because if you wanted to change something and most people say it, then you could change it. So very aligned with what Dr. Nell Wyman and we are saying, we need the data to do something about it. Very insightful. Enjoyment of answering the items. It's good because I never even thought about these questions before in my life, so the children reflect on it. So of course for us it's important from a data
collection perspective, that the children actually enjoying the activity, because otherwise we would not get good response rates. So once we have collected the data, we can map it the same way we have mapped EDI data. And just to give you a couple of examples of what we've done with the data, in one map we have linked to the socioeconomic status of the neighborhood. And as I said earlier, child poverty is one of the great correlates of vulnerability on the EDI, and we see the same thing on the MDI. There's huge variability from neighborhood to neighborhood. And you see that some of the pie charts have the majority of the area covered by green, meaning that the majority of children said they're thriving. And then you see other neighborhoods in which maybe only 25% or 30% of the children say they're thriving. And that percentage correlates very, very highly with poverty and socioeconomic status in neighborhoods. So again, one of the big barriers in our province is all the things that are associated with poverty or lack of resources. When you look at the MDI assets, so the things we ask about their relationships, peer relationships, after school activities, nutrition and sleep, you see that those in turn are also very strongly correlated with their well-being. So children who say they have all these things in their life, they're more likely to report that they're happy than not. So if you see in the background the dark color representing the children have lots of these assets in place, you see that a higher proportion of these children say they're also happy. In the neighborhoods where you see the sand color, where we have primarily an absence or a lower level of these assets, there's a lower percentage of children saying they're happy. So again, another validation of that, we're asking apparently the right questions about what differences make a difference. So for children, it has mainly to do with social relationships and with the things they get to do on a day-to-day basis with people they connect to in their social environments. So now I've walked you through a couple examples of the EDI, the teacher tool at kindergarten. We looked briefly at the student self-report in grade 4 and grade 7. And now look at the top of the development instrument, which is the younger sibling of the suite of tools, in which we're currently still developing and piloting. And this is of all the tools is probably the one where we've had engagement and collaboration with the ASC in most depths, because the ASC at the time when we started this had already been established, and basically from day one we had chances to exchange ideas around this. So I'll walk you through a couple of anecdotes of that. But before doing that, I'll give you just a brief overview of the toddler development instrument actually is. It's complemented by a parent. So now we have the teacher voice with the EDI, we have the student voice with the MDI, and now we are adding the parent voice to report on the children's well-being and their social context when they're in the preschool age. The TDI is for parents or caregivers of children who are in this age range of 16 to 20 months, so in the toddler age range. And eventually we're hoping to implement it as the other tools at a universal but voluntary level. The questions that we're asking have mainly to do with early experiences in social context, because the research says that's where you can have the greatest impact in terms of making a difference for children's health and well-being. And when we went through the research literature, we tried to identify all the questions that give us the most predictability or most predictive power in children in terms of children's later developmental outcomes. So all to say is when we chose candidate questions for the TDI, we only wanted questions for which we knew that we had the best research evidence saying yes, these things are correlated with children's concurrent well-being, and also importantly for their long-term health trajectories. So after doing some of that research, we came up with a list of different constructs that we thought we need to cover with the TDI. So we look at social interactions between the caregiver or the parent and their children. For example, whether they play with their children, whether they read to their children, whether they tell stories and so forth. We look at health, nutrition, and development-related habits, such as consumption of healthy versus unhealthy foods, whether they have access to healthcare services, whether they sleep enough on a regular basis, and so forth. We talk about family, community, resources, and barriers. do families have access to resources they need to support their children and their families, or do they face multiple barriers? Social environment support. Do the parents who have to care for the parents, do they feel supported in what they do? Do they have friends they can talk to? Do they have neighbors they can rely on and all the things? So we all know it takes a community to raise a child. So some of the TDI questions get at those topics. We also talk about the caregivers' belief in well-being. I think we actually said it earlier in the room today, but there's a strong correlation between how the parents feel. If they're stressed, chances are the children are stressed, and vice versa. If the parents are relaxed and well, they're in a better position to care for their children. Of course, their own well-being depends on how they're supported in turn by the community and the social environment around them. So finally, on the TDI, we also asked about demographic and socioeconomic background questions. And when you look at the indicator list that Dr. Weinman showed us earlier, some of the social determinants that are driving some of these health discrepancies have to do with income and employment. So it's important to acknowledge that there are, at the social determinant level, that there are determinants that influence to what extent communities and children can actually provide rich, healthy experiences to young children. So you see it's a very comprehensive, holistic measure in terms of looking at children's early environment. And just checking on time, given, you know, with the...
It's 11 minutes to 12.
Okay, thanks. So I'll give you a couple examples of this idea of two-eyed seeing, the best of both worlds. So when we engaged in developing the TDI, we engaged in multiple focus groups, and the purpose was to look at the content and discuss it with parents and service providers, because of course they were the ones we would be working with. And the parents and service providers provided feedback on the importance and the relevance of the questions, on the clarity of the questions, and the appropriateness of language that we used in the survey. We had several meetings with the ASC over the years to discuss similar questions, including ideas around data agreement and sharing. And then I'll just highlight a couple anecdotes that stood out for me. We had a focus group with the Victoria FNHA Center. Corinne Sackmeister at the time was there and facilitated. Diana Elliott came down to meet with the group. And one of the things that came out of the meeting was that it's really, really important that when you ask parents all these questions, to frame it in a way that feels safe for parents to respond to all these questions. So after the meeting, we worked hard to reframe the first title page, because it sets up how parents even perceive the TDI when they get confronted with us. Because the goal, of course, is to have parents fill this out in a healthcare setting, or in a setting when they come in from immunization, or when they do go into drop-in center, play center. And so now somebody comes over and says, here's a questionnaire. As Dr. Weinman said earlier, there has been a lot of harm done with questionnaires and research. So many people may feel taken aback. So how do you frame the whole TDI in a way that they see the benefit and the value of it? And I'll just show you a couple of examples of the wordings that are now on the front page. Mind you, this is still in development, so this may not be the final version. So we inform parents that this is to collect information about the needs and early life experience of toddlers and their families, to build and strengthen family and community resources to better support the well-being of children, families, and communities. And that the TDI aims to recognize and respect the rich diversity of cultural backgrounds, lifestyles, and values in child rearing practices in Canada, and it aims to capture and reflect this diversity. And then we emphasize that participation is completely voluntary. So we don't know yet whether we have, so far we have gotten positive feedback on this type of wording, but that's one of the things that came out of the work with that focus group. Another meeting actually happened at Health with some involvement of the first Nations Health Authority and the ASC at the time, and Andy Yellowback, who of course unfortunately passed away earlier this year, but he was at the table. And after I I was introduced to talk about the TDI, he said, you know what the issue is with your questionnaire? I said, this is really interesting. I have not even said a single word about the questionnaire. He can't know. And he said, you're not asking about residential schools. And I said, you're right, we're not asking about residential schools. And it came up in other focus groups. So he, of course, reflected on the history and said we can't understand some of the intergenerational trauma and how current family and community environments are affected by this history. So we acknowledged that, and we dug deeper. One of the things we have to acknowledge, because it's such a sensitive topic, we have not gotten to the right answer yet, or to the right solution. We know that there's an important question or something important to address, but we don't know exactly how to do it in a meaningful, culturally safe way. So for the most part, people say, yeah, this is really important to acknowledge. It would be good to have data, but it's really sensitive, so it could backfire if you do it in a way that's not culturally safe. And we're still in that space trying to figure out how to ask the question appropriately. We have had quite a number of regions participate in the pilots, and good east to west representation across the province. And just to give you a sense of the complexity of working in that age range, you have to, in order to get all the parents, you have to engage with public health, early years centers, ideally also with physicians, with strong start programs, with family child drop-ins, with infant development programs. We have been partnering with the AIEP and IAEP, support child development and so forth. So there's a whole range of programs and initiatives that have been part of the pilot work when we went out to do pilot data collection with the TDI. And I want to highlight a few of the Indigenous agencies or services by region that were involved in the different pilot sites. So for Kamloops, we had a couple, Lower Columbia region, West Kootenay and Comox and Campbell River. I'm happy to, of course, share the slides after. But all to say is we work with the networks, the ECD networks that were organically evolving when we reached out to communities and we wanted to partner with the TDI pilot data collection. And these are the groups that came forward and were partnering in the pilot. I realize we're getting closer to time, so I think I just want to stop by saying a few words about next steps. Obviously, we're here today together with the FNHA presenting jointly following the ASC meeting. And we are hoping that we can continue building on the existing partnership and expand it to see how we travel in this direction together. Including all our partners and stakeholder groups, and of course including you. And a couple of great news, because we have come to the end of a grant with the Lawson Foundation just this past year, and of course had to look for additional resources to continue the pilot work with the development work. And we just in the past month got a partnership grant and a Vancouver Foundation grant to continue this work with five of the communities that have been part of our pilot work, including some of the partners you saw earlier on the slides. And so we're hoping to continue in this process of two-eyed seeing, coming up with a questionnaire that gives us the most meaningful and most impactful data to then improve support systems for children and young families in the province. So thank you for listening while I was speaking, and sorry for the hiccup with the slides. Thank you.
Any questions for Dr. Wu? All right, thank you again for the small program.
I'm sorry, guys. I was just thinking, Martin, perhaps for some of our First Nations Health Authority guests, if you could just talk a little bit about the scale of these projects that are sort of 15-year history and the numbers. because I don't think that we caught that part of it.
Yeah, it's good to get reminded. We're so in part of it, we may not see what we should have mentioned. Yes, the EDI data collection has happened at the population level or the provincial level for the past 15 years. So a couple of slides that were disrupted show actually the trends over time. So we can look at how child development in BC changed in the past 15 years. We see that vulnerability has gone up over the past 15 years, but because it's not just a sample-based survey, we can actually say this represents the entire population of kindergarten children in the province. And in that regard, it's quite unique, not just nationally, but also internationally. There are only a few initiatives that collect population-level data on children's early health and well-being. The same with the MDI, the school districts that have participated at a universal level. Usually participation rates have been in the range of 80% or higher. So again, when we map the results for the MDI student survey, we can say it's representative of the majority of the student body. And with the TDI, we're not in that range yet, but it's the same idea. We're trying to basically get to a census level of indicators around child well-being. So the numbers, given that we have about 40,000 plus in a given birth cohort, each of the EDI data waves contains 40,000 plus individual records of how children are doing. And with the MDI, we're not provincial coverage, but we have covered, I want to say, around half of the province in terms of school districts today. Thanks for bringing that up. That's great.
My turn. Now, would you be able to, let's say I'm from school district 23, and you look at the EDI and let's say there's vulnerability in one domain, can you look and see how then the grade 4 and grade 7s are doing, and look and see, like, have the vulnerability increased or decreased? And would you be able to do that with the TDI as well, like sort of look from here to here to here?
Yeah, that's one, exactly, that's one. I'll just repeat the question for the sake of the webinar. So can we actually then make a connection between the data we collect on the EDI for kindergarten children to the MDI, so grade 4 and grade 7, and respectively, can we do the same with the TDI once we collect data on their early experiences? And for the EDI and MDI, we can already do some of these connections. We do see that the EDI predicts children's later well-being, and it's domain specific. So children that are more likely, that are doing well socially, they're more likely to feel more connected to peers and adults later on. We see that children who have lower emotional maturity, they're less likely to feel well later on. So we see there's a connection or a bit of a trend when you connect the kindergarten data to the grade 4 data. We also see that communities that had a lot of resources put towards children's service, that have economic resources that can, at least in theory, be channeled to support families and children, they're more likely to buck the trend. So we see greater deflections between kindergarten and grade 4 outcomes in communities with rich resources compared to those that have few resources. And for the TDI, we have not done the linkage yet, but we know from research that all the things we ask on the TDI in terms of the social context, they are strong correlates of children's well-being over time. So yeah, the goal is to do more of these linkages in the future, but in terms of linkage rates, we're really just at the beginning in terms of some of the research.
Can I just ask you to speak a little bit about knowledge exchange and knowledge exchange planning in terms of children and families and sharing data and information?
Yeah, so the reports for I'll talk about the MDI and EDI primarily. So the reports and the data are shared with communities in multiple ways. First, at the community level, we have maps, and I think that was also one of the distorted slides earlier on, but we have maps for each school district or each health authority that shows the neighborhood-to-neighborhood variability in terms of child outcomes for each of the EDI domains we're measuring. And these are presented online on our website. They also go into community reports or school district reports that then are shared with stakeholder groups in the respective school districts and health authorities. Then for the EDI data, we also prepare school reports. So each participating school receives a report on the results for their own schools, but those data are confidentially only shared with the schools. So they're going to be the gatekeepers. So the community reports are openly available or publicly available. All the school reports only go to the schools themselves, and they decide how to share. And that's the same for the MDI. So we have a kind of public level and a more confidential level in terms of how we share the data. Apart from sharing the data and mapping these, we have an entire team, a knowledge translation team, that has been working on providing complementary information around the data so that when people see the maps and see the results of the data can actually make meaning of it. So it would very carefully explain what the different domains mean, why we collect them, what the research evidence is, and what some of the things are that communities or schools may be able to do in order to support these domains of development. Well, I'm saying that I should, you hope there will be time for you to talk to some of the people on the KT team, because there's an entire apparatus of and history of work that goes into just the aspect of how do we meaningfully disseminate the research knowledge and create leverage in communities.
Hello again.
Once again, we have a small my appreciation. We are at the end of our morning. I like the idea of being asset-based. I don't understand the idea of like digging a hole for myself and then just jumping in. Dig 9 more holes and build a hot tub. Right? Stay asset-based. You are singularly. Yeah. Got it. It's always important to understand that you are singularly the greatest asset in your life. Yeah, nothing happens without you. So celebrate that. Always remain positive, remain asset-based at all times. Okay, please. So to close out our morning, we're going to ask Musqueam Knowledge Keeper, Shane Point, they come up with some closing remarks and close in a good way.
Wow! I was invited by the First Nations Health Authority to participate at the Knowledge Keeper level, and I want the young lady to know that her presentation. I'm amazed at the amount of time in that you have and the excellent presentation you made. So I want you to know that you did an excellent job. As well with the young man who just finished. Excellent job. I know now more about the health authority and the actual magnitude of it. It's huge. First one, we all need to remember that it's the First Nations Health Authority in the country. Holy smokes, what a huge job for Joe Gallagher and his team to put that together and continue to work it. As well, what I enjoyed about the talk about data is that they actually asked kids. Wow. I worked for the Vancouver School Board for 2 years, and my boss asked me one day how I was doing, and I said I was doing good. And he said, well, how do you know? And I went, well, I asked myself, how am I doing? And I went, really good. And that wasn't acceptable to him. So he said, you need to find a measure. So I thought about it for the day. Next day I went to school. I'm with kindergarten children in the morning. And at the end of what I was doing, I said, I want you to provide me with a drawing of what you heard. I'm here with you. What did you hear? And I want a drawing of what you learned, because those are two different things. Over the next year, the information I got from children, absolutely amazing. Absolutely amazing. Of course, you ask teachers, and they have a different point of view, and they're going, oh yeah, well, you know, you could have did better at this, and this is how you engage kids. But the information that I gained from children helped me become a better educator. Helped me become a better educator, and in that I was truly grateful to them. So the information that you provided this morning, absolutely wonderful. I learned today. So I want you to know that. Learn more about the health authority. Awesome. It's good you're here. Happy that you came to British Columbia to help us out with such a huge and wonderful task. Sometimes I think probably people at the health authority think it's really hard, but actually it's a lot of fun. And it's a wonderful place to be because you're creating. You're creating something. My aunt created that ball. Susan Point, she created that, she carved that. They gave her a piece of wood and said, make something. She went, oh, okay. Lyle Wilson, do good stuff on that piece of wood. All they gave him was the wood. And Lyle Wilson said, oh, okay, here it is. Wow. Beautiful. Same with these two poles that come from up north. Beautiful. They start raw. Here it is. Without the help of data, can't help kids. We need to know what they're thinking so that we can help them, as well as their parents and others who are involved. So I had a wonderful morning, and I'm going away from this moment richer. Why? Because all of you are here. As I sit and I watch, not only the speakers, but when I listen to the questions that were asked, excellent questions. We can't move ahead without excellent questions. The children that I work with, I provide them with an opportunity to ask me any question they wanted. And those questions help me as well, because they're good, intelligent questions. And I was with, I think they were grade 3s, awesome people. Little girl puts up her hand, girl student puts up her hand. Well, they all put up their hand. You ask anybody from kindergarten to grade 5, do you want to ask a question? Oh, all the hands go up. And they all have 100 questions. It's awesome. So she puts up her hand, she goes, really makes her soft present. And I said, that young lady right there. And she looks at me and she goes, Shane, how come you're so fat? And I went, that's a really awesome question. So I have to tell her because I don't eat properly. But it's a good question. She wants to know. And I said, well, I don't eat properly. I don't eat the right foods. I don't eat fish. I don't eat deer. I don't eat those good things that I need to be slim and strong. And she looks at me and she goes, then Shane, today you should start eating better. And I said, I'll do that. And she says, it'd be really good if you walked too. have fun with the rest of you. Thank you very much. Thank you.
And with that, we'll close the morning, but we'd just like to recognize somebody here that from the Human Learning Partnership and from the ASC that we really helped us out with this event today. And we kind of miss her huge. And it was really funny because I always wait to come down here for my meetings and Human Learning Partnership to see her. And then I realized one day, I've got her phone number. So even though she's not there anymore, I don't get to come down and see her. I'd just like to have this for Jillian to come up, and thank you so much for helping us out.